Hey, hello everyone, and thank you for joining us today for this session of the Susan Samueli Integrative Health Institute's research webinar series. My name is Shaista Malik. I'm the UCI Associate Vice Chancellor of Integrative Health and the Executive Director of the Susan Samueli Integrative Health Institute. Before we start, I want to review a few Zoom housekeeping items. We are recording this session, and after the session, we will post this webinar on our YouTube channel. Everyone will remain mute to limit distractions during the presentation, but please feel free, and we'd really like you to communicate with us by taking advantage of the chat feature at the bottom of your screen. And at the end, we'll have a question and answer session. So we really would love for you to pose questions then. The Samueli Institute is committed to whole person health research, education, and clinical care. Our interdisciplinary researchers are dedicated to exploring the science of disease prevention and treatment. And so we bring this series to you to share the promising integrative health research that is occurring through the Institute's pilot studies grants, the Samueli Scholars Awards, and our endowed chairs. To date, the Institute has supported 25 investigators with the potential to enhance our understanding of integrative practices. For more information, you can visit our website to get details on each of those studies. So our first speaker today is Dr. Karen Lindsay. She's a registered dietitian nutritionist with expertise in maternal and child health, nutrition, stress interactions, and mindful eating. She also serves as an assistant professor in the UCI Department of Pediatrics, as well as early career chair for integrative health in the UCI Susan Samueli Integrative Health Institute. Dr. Lindsay conducts studies with pregnant women to understand the effects of nutrition and stress on maternal and infant health outcomes. She also provides weekly nutrition clinics at the Institute's clinic, where she counsels a diverse patient population on ways to improve health and wellness through diet, mindfulness, and lifestyle. Please join me in welcoming Dr. Lindsay.
Thank you, Dr. Malik. So I'm very happy to be here today, and I'll share my screen. So I will be talking today on the connection between nutrition and inflammation in our body and how it relates to health and disease. So first of all, the objectives of my talk are to define inflammation in relation to health and disease risk, discuss the role of inflammation in diet-related chronic diseases, discuss key nutrients and nutritional components associated with pro- and anti-inflammatory processes, and review current evidence that links nutrition and dietary patterns to inflammation and disease risk. So I'm sure many people on this webinar are familiar with the difference between acute and chronic inflammation, but as an overview, acute inflammation is a short-lived physiological process that involves a set of symptoms as listed here. It usually only lasts minutes to days, and it's considered a beneficial immune response to when we experience injury, irritation, or infection in our bodies or in any specific tissue or organ. But the resolution of residual inflammation after the acute response has happened and the repair of the damaged tissue is required to restore homeostasis. In contrast, chronic inflammation is a persistent low-grade inflammation that when it may happen because of failure of the resolution to an acute inflammatory response. And it is a long-term physiological process. It could last even up to years, and it's typically harmful because chronically inflamed tissues produce bioactive compounds that sustain the inflammatory response and eventually leads in suppressed immune response and eventual chronic disease. So this graphic here outlines how when we have acute inflammation, if the resolution response does not occur adequately or completely, we do not get full healing, and instead we get chronic and unresolved inflammation that then results in either fibrosis and/or cellular senescence in tissues and eventually can lead to chronic disease. And some examples of chronic diseases that arise from chronic inflammation are listed here. This is not an exhaustive list, but it is quite diverse. It spans from metabolic conditions, GI conditions, neurological, cancer, skin disorders, autoimmune conditions such as rheumatoid arthritis, etc. The factors that promote chronic inflammation or that failure of the full resolution response Some factors are listed here. They could be external environmental toxins, unresolved viral infections. I mean, if you think of COVID-19 and long COVID, that's really what we're looking at. Cigarette smoking, psychological stress, obesity, etc. But poor nutrition is really the main factor that I'm going to focus on in this talk. Before I get into how nutrition is related to inflammation, I just want to overview the processes involved in inflammation. So when we have an injury or an infection in a tissue, which is this side here, and this is the bloodstream, we get white blood cells infiltrate into the site to help deal with that injury or infection. They secrete many factors that are involved in the response to try to deal with this infection or injury. But some of the factors that are really important I'll be focusing on in this talk are the cytokines and inflammatory eicosanoids. And I'll be mentioning them a few times. So these are needed to act on the local injury, but they also don't just act locally, but get secreted into the bloodstream, where they can then exert systemic effects and systemic inflammation throughout the body. In order to resolve this acute inflammation and get back to homeostasis, we need to decrease, the body needs to decrease eicosanoids and cytokines again. And at the same time, increase what we call SPMs, or specialized pro-resolving mediators, such as resolvins or protectants, because these help to basically finalize the healing process and also activate the AMPK cell signaling pathway, so that we can get full resolution and healing, and at the same time decrease the pro-inflammatory cell signaling pathways, such as through NF-kappa B being a main one. So the overall pathways that we need to combat chronic inflammation are to reduce the existing inflammation, like the cytokine and the eicosanoids that are being elevated, to also increase the resolution response through those SPMs, and alter gene expression by upregulating the AMPK pathway and downregulating the other pro-inflammatory pathways. How nutrition is involved is in many ways, and I'll be outlining some of the key nutrients, nutritional components that are involved. As listed here, some are pro-inflammatory and some have anti-inflammatory effects. Saturated fatty acids and gluten are in gray here, just to highlight that the evidence base for those being pro-inflammatory is less robust than some of the other factors, at least in human studies, but I'll still be touching on them. First of all, caloric restriction is probably known to be one of the most effective approaches for improving health span, that is longevity with good health in multiple species, including humans. And here we're talking about moderate caloric restriction, maybe 20 to 25% reduction from typical calorie intake, but making sure that it does not induce malnutrition. There's adequate protein intake, adequate micronutrient intake as well to support good health. And the pathways by which caloric restriction decreases inflammation there are many, and as we can see in this diagram here, and it's quite a convoluted multi-system process that's involved. And just to highlight some of those mechanisms, we get increased intestinal integrity through alteration in the gut microbiota composition, which then also produces more saturated short-chain fatty acids, which have direct anti-inflammatory effects. Decrease in anabolic hormones, because we've got less blood glucose excursions. That also decreases mitochondrial activity, which together decrease the pro-inflammatory cell signaling pathways through mTOR and increase the anti-inflammatory cell signaling pathways listed here. Altogether, this can promote a switch between relying on glucose as a fuel source and having the flexibility to switch between glucose, ketones, and fat mobilization from the fat stores, using them as fuel sources. And together, these alter different hormone responses in the body, decrease oxidative stress, and collectively reduce pro-inflammatory cytokines, increase the anti-inflammatory cytokines, and the more anti-inflammatory balance in macrophages. So without caloric restriction, even, I really need to touch on the balance between the omega-6 and omega-3 fatty acids, because this is another pathway related to nutrition that is really critically important for the inflammatory response. That is because the pro-inflammatory eicosanoids that I mentioned earlier are pretty much exclusively derived from omega-6 fatty acids, and particularly arachidonic acid. On the other hand, the long-chain omega-3 fatty acids, such as EPA, DHA, these promote anti-inflammatory eicosanoids and also those SPMs that are involved in the resolution response to inflammation. So they really can have opposing effects in regards to inflammation. but also the pathway when we consume omega-6 in the diet, mostly from linoleic acid, which is abundant in fried foods, heavily processed foods, vegetable oils are a huge source. This needs to be converted, and it is converted through multiple enzymatic steps to reach arachidonic acid, which then has the pro-inflammatory effects through producing eicosanoids. On the other hand, when we consume omega-3, especially if we consume it from plant-based sources like nuts and seeds, this alpha-linolenic acid also needs to be converted through multiple steps to reach the long-chain EPA and DHA, which have anti-inflammatory effects. But the same enzymes are involved in each conversion step to get to arachidonic acid on the omega-6 side, and the same enzymes used to get to EPA and DHA. So there is competition between them. So if we have more omega-6 in the diet than omega-3, the omega-6 wins basically the competition, and the enzymes focus on producing arachidonic acid as opposed to EPA and DHA. So that's how we tip the balance, either pro or anti-inflammatory, using omega-6 or omega-3 fatty acids. And we can help ourselves by consuming oily fish, which is a direct source of the long chain omega-3. So we bypass the need for this conversion step as well. In terms of the ratio between them, the standard American diet provides maybe up to a ratio of 20:1 omega-6 to omega-3, which is a lot of omega-6. The optimal balance probably lies closer to a 4:1 or a 1:1 ratio. So we're pretty far away from that on average. We can see from human studies the benefit of adding in more omega-3 in the diet. It's easier to do this through supplementation of omega-3, especially in higher risk patients. So for example, in patients with severe obesity, we know adipose tissue is an inflammatory tissue, and there is an increase in anti-inflammatory eicosanoids and a decrease in the inflammatory gene expression with omega-3 supplementation. Also decrease in CHD events among patients where they're at risk because of elevated triglycerides, and generation of those specialized pro-resolving mediators in patients with coronary artery disease. So increasing omega-3 in the diet can have profound anti-inflammatory effects. Separate to the omegas in the diet, just looking at trans and saturated fatty acids, intake of trans fatty acids associated with sudden cardiac death through multiple pathways, including activation of NF-kappa B, is very obvious from the evidence that trans fatty acids are not helpful for us, and that is why they've been mostly eradicated from the food source, but they are still present, especially in heavily fried and processed foods. Trans fatty acids also get incorporated into red blood cell membranes, and that is associated with heart failure, chronic heart failure risk. On the other hand, saturated fatty acids, there is mostly evidence from in vitro studies, not studies in humans, but they are associated with increased macrophage production and secretion of pro-inflammatory cytokines. In some human studies where they have looked at swapping out saturated fats for monounsaturated fats in the diet, that was seen to decrease oxidative stress, but only in the post-meal state. So in fasting state, there was no difference according to the diet of saturated versus monounsaturated fats in these inflammatory markers. And that was in particular in patients with metabolic syndrome. So the evidence is not totally robust to looking at the benefit of just decreasing saturated fat in the diet. And that's probably because foods that are high in saturated fat also tend to be high in either trans or omega-6 fats. So it's very hard to tease apart where the direct effect of saturated fats really lies. And then switching gears to carbohydrate in the diet. Sugar and the glycemic index of food is important to consider because high GI foods result in this glucose excursion in the blood quickly after eating a meal, which then plummets back down, whereas a low GI food has a more gradual response in blood sugar levels and it doesn't dip low afterwards. Examples of high versus low GI foods are here. This postprandial glucose excursion promotes oxidative stress and inflammation, which is thought to be associated with the risk for diabetes and CVD. High GI carbohydrates also increase that NF-kappa B activation, the pro-inflammatory pathway in healthy subjects, so even in those without chronic disease. And then high fiber diets, on the other hand, tend to be rich in low GI foods and less added sugars and less refined carbohydrates. And high fiber diets are associated with decreased CRP concentrations in healthy subjects, which is thought to be moderated by changes in the gut microbiome composition. So fiber, we know, feeds the healthy gut bacteria, and through pathways through the gut, and healthy bacteria secreting short-chain fatty acids, we get decrease in pro-inflammatory cytokines. High fiber diets also tend to go hand in hand with polyphenols, because polyphenols are compounds derived from secondary metabolism of plant foods. They tend to be the chemicals responsible for the rich colors and aromas in plant-based foods. And really important point is that polyphenols are probably the most potent effectors of the AMPK signaling pathway, and they do this by binding to other compounds called sirtuins. By promoting the AMP pathway, we promote healing and resolution of inflammation and also decrease the pro-inflammatory cell signaling pathways. And out of all polyphenols, the subgroup anthocyanins seem to be the most, have the most potential for activating the AMPK pathway. And these, the richest source, are found in berries. And it is the dark, the red, the black, purple colors of berries, which we also get in some other colored fruits and vegetables, that is where the anthocyanins lie. So selecting lots of fruits and vegetables with those deep dark colors means you're probably getting more anthocyanins in the diet, and higher anthocyanin intake is associated with a decreased risk of CVD, and especially in women. Some clinical evidence for the effects of the anti-inflammatory effects in a study where they took people who smoke, which we know they have a very high risk of inflammation in their body. It was found that supplementation after 30 days of anthocyanins significantly decreased markers of oxidative stress. However, when they stopped supplementation after 40 days, those oxidative stress markers returned to baseline. So that really highlights that consistent, healthy diet with lots of polyphenol-rich foods are really important to benefit from the anti-inflammatory effects. And then the last dietary component to touch on is gluten, which is the primary protein in wheat. It's also found in barley, rye, and oats. And it's important to distinguish between celiac disease versus non-celiac gluten sensitivity, because celiac disease is an autoimmune condition where we know there is inflammation and damage happening in the lining of the gut, whereas a non-celiac gluten sensitivity, it can result in a whole host of symptoms that might look similar sometimes to celiac disease in terms of the GI symptoms. But there is not any obvious or notable inflammation in the small intestine in non-celiac gluten sensitivity. So we do not see damage to the gut, but sometimes some of the other symptoms are suggestive of inflammation elsewhere in the body. For example, joint pain and joint swelling, headaches, or migraines in some people. Sometimes you get skin flare-ups as well, like psoriasis symptoms, which are suggestive of inflammation. And in clinical practice, often we do remove gluten from the diet to see if this clears up some of the symptoms, and especially with other autoimmune conditions, whereas not celiac disease, sometimes removing gluten in the diet appears to decrease some of these inflammation-related symptoms. But the clinical evidence from randomized controlled trials for gluten-free diets is limited outside of celiac disease. One of the autoimmune conditions is Hashimoto's thyroiditis, which is often associated with benefit from a gluten-free diet. And in one study where they were followed, these patients with this condition followed over 12 months, found to have a significant reduction in TSH levels in the gluten-free diet group versus control. However, there was no significant difference in their thyroid antibody levels or free T3, free T4, so the thyroid hormones between the groups. Even though within the gluten-free diet group, there was a reduction in the anti-thyroglobulin antibodies over time. So there's some suggestion of benefit from a gluten-free diet in this patient group, but really more research is needed, and also with other autoimmune conditions, to see if gluten-free diet is worth it, and if it outweighs the cons of removing gluten from the diet, which could include reducing total fiber intake, which is arguably not going to be helpful for gut health as well. So to wrap it all up, we don't eat individual nutrients, we consume foods and overall dietary patterns, and the anti-inflammatory dietary pattern has been proposed and depicted here in this food pyramid. And it's very similar in many regards to the Mediterranean diet, in that it emphasizes lots of vegetables, fruits, nuts and seeds, fish, unprocessed meat and legumes. But there is some further emphasis and nuanced emphasis on the types of fat, the quality fats, to avoid vegetable oils because they're rich in omega-6, for example. Whole soy products, but preferably organic. Asian mushrooms can have anti-inflammatory effects. Low GI whole grains rather than other refined grains. Lots of herbs and spices, and emphasizing the polyphenols, especially from things like berries and green tea, etc. And the evidence base for prescribing this type of dietary pattern in patient groups is again limited. But one study which looked at anti-inflammatory diet in patients with diabetes or pre-diabetes versus just a healthy diet recommended by the American Diabetes Association. And this study, foods were provided to patients, which increases their compliance. And it was found that both diets basically equivalently reduced markers of inflammation, especially when it was accompanied by weight loss. But there was no significant difference in reduction in glucose, lipids, or triglycerides between the two groups. So inconclusive, basically, if the anti-inflammatory diet is more effective than a regular healthy diet for diabetes patients. In another study with rheumatoid arthritis patients, a crossover study, again, some food was provided to the patients to help compliance to the anti-inflammatory diet. When they were in the anti-inflammatory diet phase, it did result in a reduction of disease severity scores reported by the patients in the rheumatoid arthritis symptoms compared to when they just ate a regular controlled diet. So some suggested evidence of prescribing this overall dietary pattern, but again, more research is needed. And in conclusion, diet has strong potential to attenuate chronic inflammation and induce the resolution response. In particular, we see benefit from moderate caloric restriction, from improving the ratio of omega-3 to omega-6 fatty acids, avoiding trans fatty acids, avoiding high glycemic index diets, and promoting more fiber in the diet to improve gut health and intestinal integrity, and consuming lots of polyphenols, but in particular, we get benefit from those anthocyanins from berries and other darkly colored fruits and vegetables. And there's potential benefit from gluten elimination to decrease inflammation for some autoimmune conditions, but further research in human studies is required. So thank you for listening. I have lots of references. We share the slides afterwards, you can see them. And I'd like to pass it back to Dr. Malik.
Thank you, Dr. Lindsay. That was excellent. And, you know, we have a lot of participants, so please make sure that you are thinking of questions to put into the chat feature or into the Q&A. We can see both. And that was just excellent. I think you set the framework for looking at various dietary components that influence inflammation. And thank you for reviewing the evidence, which, you know, it's still, we're still in an infancy stage when it comes to evidence for various dietary changes to address inflammatory related conditions. So for our second speaker today, we have the pleasure of hearing from Dr. Angela Fleischman. She's a UCI health physician scientist investigating hematological malignancies. Dr. Fleischman integrates her research with the clinical care of patients with these blood disorders. She earned her medical degree and a PhD in cancer biology from Stanford University. She then completed an internal medicine and medical oncology fellowship at Oregon Health and Science University in Portland. She joined the UCI Health Chow Family Comprehensive Cancer Center and the Department of Medicine as an assistant professor in 2013 and began developing an independent laboratory group focusing on the pathogenesis of myeloproliferative neoplasm, or MPN, a chronic leukemia. Her research interests also include hematologic malignancies and stem cell research. Her overarching research goal is to identify what drives disease initiation in MPN and ultimately to translate her scientific discoveries into therapies that benefit MPN patients. She's also part of our inaugural class of Samueli scholars, recognizing really distinguished professors who are doing high-level, national-level work in integrative health. So please welcome Dr. Fleischman.
Thank you very much for that very nice introduction. So thank you for listening today. I'm going to focus on ways to address inflammation through diet, in particular with a specific focus on optimization of, I would say, the blood system, going more into detail about some pilot feasibility studies we've performed here at UC Irvine on the chronic blood cancer myeloproliferative neoplasms as a model disease for utilizing diet in chronic leukemias and potentially also in precursor conditions that are very common among the general aging population. Let me see if I can share. Oh, okay, there we go. Okay, sorry about that. So we heard Dr. Lindsay talk a lot about general negative impacts of inflammation and how diet can impact inflammation. There is a wealth of information about inflammation in chronic diseases, and we're learning more and more that chronic inflammation also has a significant negative impact on our blood system. So it's known that chronic inflammation can exhaust blood stem cells. Inflammation makes the blood stem cells cycle, and they can only undergo a finite number of cycles before they exhaust, and that could potentially lead to some bone marrow failure syndromes. In addition, we're learning that chronic inflammation plays a key role in the outgrowth of mutant cells, which early on can contribute to things like increased cardiovascular disease and increased blood clotting, but in the long run can also be the precursor for blood cancers. So this is a picture that I tried to make to display the impact of inflammation on the development of blood cancers. On the left, I have a healthy blood system, which is present in younger people. And interestingly, as humans age, it's very common to develop a new phenomenon called CHIP, or clonal hematopoiesis of indeterminate potential, meaning there's mutant blood cells without the presence of a identifiable blood cancer. And chronic inflammation promotes the development of CHIP. Things like smoking do increase one's risk of CHIP. And what's even more interesting is that the CHIP cells, the mutant cells, further create additional inflammation, which then promotes their own growth. The mutant cells can grow up to a big enough bulk that then they do cause a identifiable hematologic problem. And this is a chronic hematologic malignancy like myeloproliferative neoplasm that I will be focusing on. Then if the chronic hematologic malignancy can get out of hand and then develop into an acute leukemia, which has severe negative impacts on people's blood counts. So CHIP is very interesting to me, and in my perspective, is an ideal patient population, or they're not patients, they're healthy, honestly healthy aging adults, in which addressing chronic inflammation can have a significant impact on their long-term outcomes, including blood cancers, as well as including cardiovascular disease. So this CHIP is very common among aging humans. As you can see, upwards of 20% of people over the age of 60 will have CHIP. And interestingly, CHIP has been demonstrated to have some negative effects on human health, including a risk of cardiovascular disease. It's found in animal models, the presence of these CHIP mutant cells can actually accelerate atherosclerosis in mouse models. However, because we don't screen for CHIP in the general population, it would be difficult to target these people at the present time for large interventional studies. However, people with chronic hematologic malignancies, in which we do know that chronic inflammation plays a key role, are readily identifiable by virtue of abnormal blood counts, and do see hematologists for their care, albeit many times people with these disorders, including myeloproliferative neoplasm, really are maintained for decades without really any intervention whatsoever. So this is a great population in which lifestyle interventions such as diet could play an important role in changing the disease trajectory. So we focus on myeloproliferative neoplasms, which I think is a very nice model disease to study chronic blood cancers in general. Myeloproliferative neoplasms arise from mutant blood stem cells that lead to excessive blood cell growth and can cause blood clots as well as increased cardiovascular disease. And increased inflammation is well characterized both in human MPN patients as well as mouse models of the disease. And the consequences of the inflammation are very broad in myeloproliferative neoplasms. Patients suffer sometimes from debilitating symptoms that are many times driven by increased inflammatory cytokines. At the later stages of the disease, patients can develop anemia, and that's thought to be due to increased inflammation, which does not allow them to utilize the iron in their body to make red blood cells. And also thrombosis or blood clots, which is a key problem in MPN, can be worsened by chronic inflammation. What drives inflammation in MPN is a very interesting question. Although the presence of the mutant cells in one's body does increase inflammation, there are other lines of evidence to suggest that inflammation may predate the acquisition of the mutant cell itself and may play a key role in why some people get this disease and some people don't. We wanted to brainstorm first quite a while ago about potential approaches that would be low risk and low costs interventions that could be utilized to reduce inflammation in MPN. And so we thought of diet because it's been demonstrated to play a beneficial role in other chronic inflammatory diseases such as cardiovascular disease. And what sort of diet to try? We focused on a Mediterranean diet because of large interventional studies utilizing this diet in cardiovascular disease, in which they found reductions in biomarkers of inflammation. So we figured that the Mediterranean diet was a good diet to try in a chronic blood disease patient population. So the properties of the Mediterranean diet: it has high fiber, high in antioxidant compounds such as resveratrol, and fats are primarily from the good monounsaturated fatty acids. So we've completed 2 diet interventions thus far at UC Irvine. I'll go into more depth on each of these, but just as a broad overview, they were both pilot studies to look at feasibility. I want to be clear about that. We weren't powered or had enough patients specifically to address outcomes. Our primary objective was to see the feasibility of dietary interventions in this patient population. Our first diet intervention was done with in-person registered dietitian counseling, and the second dietary intervention was done fully as an online intervention with Zoom-based registered dietitian visits. So in our first study, we randomized 30 MPN patients to either a Mediterranean diet or standard US guidelines for Americans. They had a 2-week lead-in phase where we simply wanted to observe what they were eating, observe what they were, how their symptoms were being managed, and collect biological samples for their baseline. Then they underwent a 10-week active intervention period in which they had in-person dietitian counseling visits, as well as weekly written in a PDF colorful format curriculum on a Mediterranean or a standard US guidelines for Americans. We collected data in terms of what they were eating and how they were feeling using validated surveys that are widely used in the MPN patient population. This is on the left was our primary objective to see whether if we gave MPN patients Mediterranean diet counseling, could they change their eating patterns more towards a Mediterranean diet eating style. And we utilized, there's a 14-point Mediterranean diet score, which asks about intake of things like olive oil, nuts, and other items that are in a Mediterranean diet, with a score of about 8 or higher, generally regarded as adherent to a Mediterranean diet. And as you can see in the pink line, which is the Mediterranean diet group, during the active intervention phase, which is the period of time that's shaded in yellowish orangish, we had a good proportion of the patients achieving a Mediterranean diet adherence score of greater than 8, whereas at no time period did the other group achieve a over 80% adherence to a Mediterranean diet. And then on the right, we looked at symptom burden using a tool called the MPN SAF, which is used in all clinical trials for MPN to quantify symptom burden. And we found that, interestingly, although both groups did enjoy a reduction in their symptom burden, it appeared that the pink group, which is the Mediterranean diet group, enjoyed a greater reduction in their symptom burden. Again, the symptoms were included simply as an observation and exploration. We need to do further larger studies to specifically, statistically determine whether a Mediterranean diet does improve symptoms in this patient population. Other things that we looked for, which again were exploratory biological outcomes, blood counts, cholesterol, high sensitivity CRP, inflammatory proteins in the blood, and the gut microbiome. And I will just go over a few highlights of those. So this is the inflammatory cytokines. We took the plasma at 4 different time points during the study. And again, given our sample size, we're not powered to detect any differences, but we figured it was worthwhile to observe to help us with development of subsequent larger studies. And not unexpectedly, we didn't detect any significant changes in their inflammatory cytokines throughout the 10-week diet course. And we also looked at the gut microbiome and how it could potentially change during the diet. And each person's microbiome is particularly unique. So we did not detect any significant changes in the gut microbiome over the short 10-week intervention, which is not unexpected. For subsequent interventions, we can expect to have a longer intervention that could potentially observe some changes in the gut microbiome. And because we had different types of myeloproliferative neoplasms in our cohort, in addition to investigating changes in the microbiome with diet, we were also able to tease out if potentially the different subsets of myeloproliferative neoplasms. There are 3 subsets: ET, PV, and MF, which is myelofibrosis, myelofibrosis being the more severe form. And interestingly, we found that people with myelofibrosis, the more severe form, have reduced microbial diversity, which is suggestive that they have a more deranged microbiome, which is an interesting observation. Whether this decreased diversity is simply a reflection that they're more ill in general, or could potentially play some instructive role in their disease progression, remains to be seen and warrants further investigation. In a separate study, since we're talking about the microbiome, we performed a second study where we simply wanted to observe the microbiome of MPN patients versus normal controls, because no one had fully characterized the gut microbiome of MPN patients. So we took 25 MPN patients and 25 healthy controls. Sorry. took 3 fecal samples longitudinally from each person to get an average of their gut microbiome, and did 16S sequencing. Also from a subset of the patients, we took inflammatory cytokines. And although in this cohort as a whole did not see any changes in microbiome diversity, interestingly, we did see a reduction in a specific bacteria called Faesocolobacterium, which in the literature has been suggested to be protective from inflammation. So the reduced amount of this protective bacteria in MPN patients may suggest that they have higher inflammation, or that the lack of this bacteria in their gut may promote inflammation in them. Again, this was a pilot study, and it's difficult to make any statements based on it, but does warrant further investigation. And we wanted to see how different the MPN microbiome was from normal controls. Again, each person's microbiome is very distinct. And so a small percentage of the microbiome could be explained, variants could be explained by an MPN diagnosis, and 1.7% of somebody's microbiome could be explained by an MPN diagnosis. You may think that that's a small number, but putting things in perspective, for example, a very large intervention such as a colonic surgery can explain about 5% of microbiome variation. So 1.7 is a significant, but admittedly a subtle impact on the microbiome. So to summarize the microbiome in MPN, we found that there are subtle differences in the gut microbiome of MPN versus normal, but additional studies are necessary to dissect if these microbiome changes predisposed to MPN are a consequence of MPN or change in response to therapy. Moving back to the diets, in our first diet we studied, we had quite a number of people outside of the Southern California area who were interested in participating, but because of logistics and inability to travel to Southern California for the dietitian visits, they weren't able to participate. So that prompted us to ask whether we could perform a fully online clinical trial in this MPN patient population. So again, we took MPN patients and randomized this time them to a Mediterranean diet, or our comparator diet with this study was the DASH diet. After the 2 weeks of observation, patients were given online Zoom-based dietitian counseling sessions in addition to written curriculum, and they performed surveys online, as well as diet recalls online. And our primary objective here was to see whether people can comply and adhere to the requirements of a fully online clinical trial. Not unexpectedly, all patients showed up to their Zoom-based dietitian visits, which is not unexpected given they were being provided with a free service that would be helpful for their health. We also asked them to complete daily symptom surveys for a total of 15 weeks. And many of the patients had 100% completion rate with every single one of the surveys, which is quite impressive. We also asked them to do more extensive 24-hour diet recalls, which do take quite some time, and observed that we had less than desirable completion rates of these 24-hour diet recalls. This was a learning experience, and suggesting that for more intense surveys, really a one-on-one contact with a phone questionnaire instead of an online questionnaire is probably required. And then in terms of symptom burden, again, we did find, similar to our in-person dietitian counseling, that MPN patients do enjoy a reduction in their symptom burden. So for our next steps for a diet intervention MPN, we want to do a much larger online-based intervention that is now powered to detect change in symptoms in MPN. We do want to include a no diet intervention as a comparator because we learned from our first 2 diet interventions that any improvement in one's diet quality can reasonably improve health outcomes, which is not necessarily unexpected, but we do want to specifically tease out differences between a diet intervention and no diet intervention whatsoever. And because we're particularly interested in improving the gut microbiome, we're going to adapt our Mediterranean diet with fermented foods, as well as emphasize high fiber foods to maximize the changes in the microbiome. And then to acknowledgements, the microbiome work was primarily done by a visiting scholar in my lab, Kenza El-Alawi, in a collaboration with the Whiteson lab. And the Mediterranean diet interventions were primarily done by a grad student in my lab, Laura Mendez. So thank you very much.
Thank you, Dr. Fleischman. That was excellent. I think you're really on the cutting edge of preventive oncology, and the rigorous studies you've done with anti-inflammatory diet and the early stages and of MPN are just very, very compelling. So with that, we're going to turn to our Q&A session. And if you haven't already done so, please type up your questions in the Q&A. Dr. Lindsay, start with you. You did an excellent discussion of omega-3 and omega-6 fatty acids. And the first question is from someone who follows a vegan diet, so they can't have fish oil. Is algae a good substitute for omega-3? And then I think I'll also kind of have that as a second question, kind of a subpart. Is there a difference between taking supplements like omega-3 versus eating foods that have omega-3?
Yeah, thank you for those questions, very important ones. So to answer, first of all, the algae supplement is a great alternative to fish oil. So for people on a vegan diet, it is really the only plant-based source of long-chain omega-3. So for people on a vegan diet, I actually very much encourage taking an algae supplement to get the long-chain omega-3. But in general, about supplementing versus food intake, I think with omega-3, it's reasonable if you're somebody who just either can't or does not like fish. I think taking a supplement is a very reasonable alternative. And sometimes people benefit even eating fish, but also to take additional omega-3 if they're trying to combat inflammation, because sometimes it's just impossible to get enough just eating enough fish. I think I saw on that question also about supplements regarding fiber. In that case, I would recommend try to increase fiber through dietary sources, because it's not just the fiber and the foods that are high in fiber, like whole grains and legumes and all the vegetables. We also get those polyphenols that I talked about. There's other components in the entire food that are really beneficial for both gut health and overall disease prevention that we don't get when we just rely on taking a fiber supplement, for example.
Thank you. That's really great. So the next question is for Dr. Fleischman. Dr. Fleischman, you had a very alarming statistic on, the prevalence of CHIP. I've never heard of that. And so it was really interesting to hear. I think it was 20% over the age of 60. And I think that leads us to some questions from the audience. Are CHIP cells tested for regularly? And then how would someone know if they're at risk if they're not part of a research study?
So that's a very, I did not mean to alarm people. And CHIP is actually an emerging hot topic. It was identified, I don't know, maybe 6 or 7 years ago, probably longer than that. Tell you the truth, almost by accident. So currently CHIP is not screened for in the general population. How it came up is people who have solid tumors in general get sequencing to identify mutations in their solid tumors. And then they also have a matched blood, what would be their normal. And there was observations that mutations were seen in the more in the blood than in the tumor. And so suggesting that those mutation was coming from the blood, not the tumor. And then that prompted further investigation of larger cohorts of people, including, banked, population cohorts that get the percentages of the population that have CHIP. CHIP, from my, it's well recognized as a cardiovascular risk factor, and so should be regarded as such if identified with improvement in lifestyle and really aggressively managing other cardiovascular disease risk factors. But the general population at the present time is not necessarily screened for CHIP. Given that we don't necessarily know what to do about it at this point in time, I don't necessarily know the true rationale for screening a whole population. Other times it may come up is, say, some blood abnormalities that really can't be explained, and searching for a reason why there may be some blood abnormalities. But CHIP is a very interesting scenario that we could have a whole talk on. And we try, there are some negative parts of CHIP. There are some positive parts of CHIP coming out. There was one large study that people with CHIP have a lower likelihood of getting Alzheimer's, have better outcomes with colon cancer. So there's sort of pros and cons to basically anything. So
thank you for that. So the next, I think there's a lot of questions on the Mediterranean diet. Both of you brought those up in your presentation. So starting with Dr. Lindsay, you kind of talked about the anti-inflammatory diet as building on the Mediterranean diet. So I think one of the questions is, are there different Mediterranean diets out there, and is there one that's best?
Well, I don't like to think of the Mediterranean diet as being multiple versions, but more of a blueprint, because although it originated out of the Mediterranean region, that's not very helpful for cultural adaptations in different parts of the world. So really the Mediterranean diet is like a blueprint where there's a lot of emphasis on fruits and vegetables, on legumes, as well as some lean animal protein sources, herbs and spices, olive oil as a primary fat source. And that can be adapted to meet different cultural needs. So the classifications of the vegetables or the bean sources can look different in different parts of the world, for example. So it's not that there's one is best. It's really just about proportioning out, maximizing fruits and vegetable intake, whole grains, complex carbs, legumes, oily fish, olive oil as a primary fat source, and other healthy fats, and really minimizing the processed foods, which are more abundant in the classic Western or American diet. So I hope that kind of answers the question.
And just as a follow-up, there's a question about, you're talking about legumes, question about lectins. Is there evidence about, concern about certain components like lectins, or eating certain vegetables like nightshades, like eggplant, tomato, or do we not know enough?
I think we don't know enough to make blanket. It's unlikely that as a blanket recommendation, every individual needs to avoid these, because most people can tolerate these foods fine. Nightshades is a concern for certain people, perhaps with certain autoimmune conditions where they're maybe not being responsive. Then it might be worth at least trialing taking out the nightshade vegetables out of the diet and see if that improves, because some people do have a sensitivity. But definitely I would not recommend blanket exclusion of all of those foods. For legumes and like the lectins, it can be a problem for some people to digest, or with irritable bowel syndrome might react a lot to legumes and find it difficult to digest them. And that's really where working on improving the gut microbiome comes into play. Also, pressure cooking the legumes helps to break down the lectins in their coating so that they become more easy to digest.
That's great. So Dr. Fleischman, you also, started off your research intervention with the Mediterranean diet. And it sounds like, you're now delving deeper into adding fermented foods. Is there, in your opinion, certain components of the Mediterranean diet that are more important to follow if you're really looking for that anti-inflammatory benefit?
I think I want to echo what Dr. Lindsay had said in terms of the Mediterranean diet as more of a framework and more maybe a eating philosophy or a lifestyle that I think is probably the sort of key component of a Mediterranean diet. I know people always want specific things, what to eat, what not to eat. But I think it's more of a general framework to focus on, if I would say probably, what do I think sort of the key components of if you were just going to do one thing, I mean, maybe, swapping out all of the majority of your fats for olive oil. I mean, maybe that's sort of the central key component. And, minimizing processed foods and maximizing whole grains, fresh fruits, fresh vegetables. But if you wanted one thing, my bet would be, the olive oil as the fat source. But I think it's much more broad than that.
Thank you. The next question, Dr. Lindsay, is you brought up, caloric restrictions. Certainly that has a lot of evidence for reducing inflammation and reducing insulin resistance for, and so is there a difference between general caloric restriction or caloric restriction through periodic fasting?
Yeah, that's a really hot topic, I guess, right now, is intermittent fasting or time restricted eating. And it is definitely one approach to caloric restriction, just because usually cutting out one meal a day means you're probably going to eat less calories overall in that day. The overall evidence for caloric restriction seems to be regardless of whether it's done in a time restricted eating fashion or not. So I think that time restricted eating is sort of approach that is easy for people to get into the flow of a day where they just say, okay, I just eat between these hours and I don't have to think too much more about it. But sometimes there can be downsides to strict intermittent fasting protocol if the eating window is very short. For some people, that can almost increase stress in the body and through other mechanisms, maybe even cause more inflammation or disturb hormone balance in other ways. So I think it has to be done on a case-by-case basis and probably consult with a healthcare provider before embarking on a very strict caloric restriction or intermittent fasting protocol.
Thank you. That's very helpful. Dr. Fleischman, this next question is, you mentioned fermented foods and microbiome. This question is, how do fermented foods change microbiome?
The fermented, I guess you could say that they provide a food source for beneficial bacteria.
And so to Dr. Fleischman, one more question. In integrative health, we screen for inflammation, SED rate, HSCRP, ferritin, and try to reduce these markers to prevent disease in general. Do you think that these sort of general markers are useful for determining whether someone has the likelihood of developing MPN or prevent the development of CHIP?
So that's a good question. I'm glad you brought that one up, because if we weren't going to do that live, I'm like typing up the answer right now. I think those are, I think if those markers are elevated, probably the person clearly has inflammation. However, I think that, if somebody has markers of obvious inflammation, trying to identify the source and then reverse that obviously is a good thing. But I think with our, the techniques that we have clinically today, and honestly, even, general research wise, I think we can't, there's inflammation, subtle inflammation that we at the present time don't have the ability to detect. So I would say, yes, those, rough markers are good estimates of inflammation, but I think still a lot of times people have normal markers, but yet they clearly, clinically look like they have chronic inflammation, but we just can't identify sort of, laboratory markers to sort of reveal that. And with regard to the prevention of the development of CHIP, there are a large study in a little bit more advanced stage of CHIP called CCUS that will be looking at the anti-IL-1 to reduce bad outcomes in CHIP. But that will be potentially be a very large study.
No, this is, I think, a great discussion following, amazing presentations. I think this goes to show, nutrition is a very interesting and complicated topic. There aren't really, one size fits all kind of explanation. So I think there's a few people who would love to follow up, I think, with both of you. And so I know that, Dr. Lindsay does do the Wellbeing Initiative with the Samueli Institute and is available for one-on-one visits through that mechanism, but she also sees patients at our clinic here on campus. And then Dr. Fleischman, what's the best way if people wanted to follow up and have more questions? Do you have office hours or?
I don't necessarily have office hours, but somebody can just email me if they would like. Is my email somewhere on I can just say my email or put it up somewhere, agf@uci.edu. I'm more than happy to, set up a meeting or, do stuff by email, but I would be really, and it looks like from the question and answer, if there's some people who are, interested in particular, if people are interested in, preventative integrative oncology, I'd be really excited to talk and brainstorm about ideas that we can come up with some projects to do here.
That's great. No, thank you. And thank you, Dr. Lindsay. And we will be sending an email follow-up with a link to the webinar, to the recording, as well as emails. So thank you again all for attending and for all these great questions. And thank you very much to our presenters for this excellent, excellent discussion.
Thank you. Have a good day.
Bye.
Okay, bye.
Bye-bye.